So this is a teaser for what I'm going to be talking about later on this afternoon about using the CFIR. So I'll get into a lot more detail about how we used it, but I'll just tell you briefly a little bit about the project and what we did. So we have used the CFIR at the VA Diabetes Query, the Quality Enhancement Research Initiative, for a bunch of studies, but the one I'm going to be talking about today is VA's Specialty Care Transformation Evaluation. And this consists of 4 initiatives to improve VA patients' access to specialty care. This is a big concern within the VA because we're a national healthcare delivery system. Obviously, we have a lot of patients who live in more rural areas, and these patients have challenges seeking access or getting access to specialists. The specialists are located in the big cities and the tertiary care facilities, and a lot of our patients are in more rural areas. So it's challenging for them to travel. The wait line, our specialists are limited, so the waiting time to get in to see them is can be excessive. So VA is very focused on how do we increase access to these specialists. And without going into the details of the 4 specific initiatives, let me just say that basically they're all kind of focused on helping our primary care providers do additional stuff, more preparatory work, more workups, and then some of the smaller or less complex procedures so that they can take away a little bit of work for the specialists or do some upfront work at the local facilities before the patients have to go to see the specialists. So it's a lot of training of the PCPs through some telehealth initiatives, some telemedicine initiatives, through some other sorts of mini residency training programs. But the point being, our stakeholder here is the Office of Specialty Care Transformation in VA Central Office. So this is the organization at the tippy top level who is rolling out all of these initiatives. And so they engaged us, the evaluation center, which actually consists of 4 different centers, but they engaged us to do this evaluation. So they are our primary stakeholder because they are the ones who are paying to a large extent, at least initially, for the rollout of these initiatives, and they wanted us to evaluate them. So there are 2 major sort of components to the evaluation. One, I would say is more quantitative. There's a group that is looking at kind of the outcomes and the utilization of services based on VA data sets. And then the second component is the more mixed methods, qualitatively oriented group, and that's what I'm going to talk about. And so the objectives of that group, the mixed method groups, are to understand the reasons for the differences in implementation success across the participating facilities. So, and by implementation success, I think I can accurately say it would be defined along the re-aim construct of adoption. We tend to look at what's been the highest uptake. That's what we consider implementation success. We can argue about whether that's the most appropriate measure, but we have good data on it. So we want to understand why some sites who participate in these initiatives can uptake or can have greater uptake than those who do not. So for each of these initiatives, they're not being rolled out to all medical centers, but there is a pretty good sample of facilities participating in each of these programs. So we're going to find the high utilizers and the low utilizers and try to find out the differences between them. And then based on these findings, if you can see what the differences are between these 2 groups, we can then try to make recommendations to our stakeholders about how to improve dissemination of the initiatives to other facilities who aren't currently participating in the program. So, of course, the framework we're using is the CFIR, and this was developed by Laura Damschroeder at our query with others, and I was part of that group and have worked very closely with Laura all along the way. And it does focus on those contextual factors affecting implementation success. Again, I'll go into a little more detail this afternoon, but these are the primary domains. And I think for those of you who've used other models, you'll see that, or see hopefully some overlap or some similarities with other models. That's the whole point of the CFER, but again, I'll talk more about that later this afternoon. So, as I said, this is the purpose of the design. When I think about the characteristics of the different designs that Borsika talked about, this is not a particularly rigorous design because this is something that our stakeholders asked us to do. They're rolling out this initiative. We didn't really have the opportunity to design it in the way we wanted to. So I would consider it to be an observational design. There aren't really any controls. But we are comparing. So we're comparing, as I said, sites with low implementation success versus high implementation success. So for this mixed methods component of the study, we do a purposeful sample of the facilities that are participating in the initiative, so we get the high users and the low users. And then we want to determine which of the CFER constructs rate more negatively at the low implementation sites compared to those that rate more positively at the high implementation sites. It's sort of a correlation analysis. So when we look at the constructs, and when I talk about some of the specific constructs this afternoon, or when I introduce the CFER to you, you'll see all of these different things that you've noticed can be potential barriers and facilitators, and that all of the sites might talk about. But it doesn't really matter in terms of which ones are most important, except for the ones that were barriers at the low sites and facilitators at the high sites. Because all of those constructs are potentially important. As it was mentioned earlier, the CFER has about 40 constructs. And you can't make recommendations to your stakeholders to focus on 40 different constructs. So we want to hone in on those that distinguish between the low and the high sites. And the methodology that we use for doing this, again, I'll explain this afternoon. But then once we hone in on those key constructs, which have been, for the first three initiatives, or the first two, they're about 4 to 5, so a very reasonable number. Then we can develop recommendations based on those specific constructs. So that's the key to this particular approach. So the study measures in this case are pretty much the CFER constructs. Data collection is semi-structured interviews. And the problem with, of course, semi-structured interviews, very resource intensive, but it does allow us to still rate these constructs while also collecting some very rich information, which is really key to helping us with the recommendations, because we want to find out not just that the constructs exist at the sites, or not just that they're barriers or facilitators, but how they are barriers or facilitators at the sites, because then that will directly inform the recommendations. And that's key to have that rich information to be able to do that. You couldn't get that sort of information with just a survey, but we do use surveys. Here's the mixed methods approach of a larger sample of participants to triangulate, to sort of confirm the results or refute the results of the interviews. Because sometimes when you do the interviews, they'll bring up all these constructs, but they're not really that important when you do the surveys. If you look at just the number of different respondents who say it's a problem, it's not necessarily, it doesn't necessarily coincide with the level of significance that the interview respondents seem to describe them as. So in one case, we found something that the interview respondents talked a lot about, but then when we did the surveys, it wasn't really as big of an issue. So it is important to do the surveys for that reason, to see really are these significant issues or not. Oops. So our analysis approach, we did a rapid analysis approach, which again I'll talk about a little bit this afternoon, just because the stakeholders want this information sooner rather than later. We coded the data by CFER construct. We rate each construct. Again, it's not enough to just know that leadership was an issue. Was in this particular site, was leadership poor or was it good? So you need to rate them either negatively or positively. Then we developed this matrix to look at the correlation. Now granted, this is done very subjectively because our sample size is quite small, But what we're hoping to do, because we're using the CFER across multiple studies, is we'll start to amass a repository of these data where we can do more syntheses and do some more rigorous sets of analyses than just sort of eyeballing the correlations in a matrix. But this is how we start, and this is helpful, again, to honing in on those most important constructs. We triangulate with the survey data, as I just described, and then we develop the recommendations based on the key constructs. So sharing the findings, not very earth-shattering. We do reports, presentations with our stakeholders. Those have been, I have some of my colleagues here, I would say those have been met with rather, in my estimation, with somewhat lukewarm response. I'd like to see some more enthusiastic responses on the part of them, but I think what they really need and want is a toolkit development, which we're working on next, based, again, on these specific recommendations that they can show to the sites and say, you can use these if you want to adopt these particular initiatives. So lessons learned. Oh, I forgot to mention one key aspect. In addition to these interviews and the surveys, we do site visits, which provide even yet more information in detail. Again, very helpful for our recommendations. The people who have participated in them have said they are invaluable. And this is good for me to know because I'm behind the scenes and I don't fully appreciate this. In fact, I think when I see all the effort that goes into planning for these and doing them, it just seems like so much trouble, especially given all the constraints associated with travel funding for the VA. But I've been reassured that those participating in them say they're highly valuable because you do get information that you don't get on the phone interviews, right? Is that true? So those are important. This probably goes without saying that you want to interview, when you do interview people, you want to do it with a wide range of participants because their perspectives are going to be very different. This mixed methods approach is extremely beneficial because they inform each other. The surveys inform the interview data and vice versa. And then here are a couple of references just on the CFER. The first one is the original article that describes the CFER, and then the second one talks about the approach that I just described, where you choose the low and the high sites, rate the constructs, find the ones that are most important, make recommendations. So that's our approach.
The last presentation in this section, so the one that is going to have to really bring it up to the top, is Deb Ritzwaller, and Deb just joined us this afternoon. She's working with me at Kaiser Permanente, Colorado, where we are working at the same place, I guess. And she has a special expertise in health economics, which we have not heard of from today, at least. But we did hear some other cost analysis happening, so we really look forward to your expertise in this. Thank you.
Thank you, and thanks for inviting me. So when I first got the invitation from Borsica, I thought I would present some standard, here's 101 ways to collect implementation cost data and 101 ways to analyze it. But given it is the afternoon, I thought for sure I'd put you all to sleep. So instead, I'm going to present a really cool project that used some economic analyses, I guess we could call it that, Joanne, right? To demonstrate how the analyses inform the implementation or further implementation of the intervention. And probably the person who should be giving this talk is Joanne Shoup in the back, my colleague, who actually was key to conducting both the evaluation of this project and the economic analysis. I was more like, by the way, can you talk to me once in a while about how we're doing this? So again, kudos to the team who really pulled this off, but I think it's a very, very cool example. So real quick, background on this, as many of you in the room are involved with primary care and other public health initiatives, influenza is a big deal, and it has a particularly significant effect on those with morbidity mortalities, especially around asthma or COPD. Back to technology and other uses of technology in population-based care or even in integrated care systems. Interactive voice IVR technology, interactive voice recognition software, has been very successfully used in preventive initiatives, and we are using that on a regular basis at Kaiser Permanente to collect patient-reported outcomes. And that feed into our medical record. Just a little tickler there. But the objectives of this project were to evaluate the effectiveness and costs of an IVR initiative for flu vaccine reminders targeted toward a chronic disease population. The population and setting and context, and again, Joanne, I'm looking for corrections if I misspeak here, but it was adult members at Kaiser Permanente, Colorado with asthma or COPD, the influenza vaccine outreach initiatives of the fall of 2012, and the stakeholders are listed here. Specifically, our Department of Population and Preventive Services, who do the population-based outreach to our over 500,000 members here in the Denver metro, Denver, Boulder, Colorado region. Our chronic disease managers, who are intimately familiar with these with the characteristics of the target patients, primary care departments who were very interested in how this would work, and our group at the Institute of Health Research. So back to the basics of D&I, selecting your framework. What were the outcomes of interest that we needed to evaluate? And in this case, it was effectiveness, effective of the various arms of the intervention, and costs. What were the target populations, as noted, asthma, COPD, participation? So our outcomes that we wanted to look at from that perspective were proportion contacted versus proportion vaccinated, and how representative or how were the patients identified and or recruited. And in this case at Kaiser Permanente, because we do have such amassed billion-dollar electronic medical records and registries, etc., we can identify them either through our chronic disease registries or more specifically, your membership records, or if you're enrolled with Kaiser Permanente. Choosing the study design. Who delivered in the case of an economic evaluation, these are the key issues that I always try to emphasize if you're really going to be able to understand what are the resources involved with implementing that intervention or implementing the initiative within the population. Who delivered the intervention? What were the training and supervision that were needed? What were the characteristics of the staff? What kind of training overall was required? Is it a nurse? Is it a doc? Is it a public health worker? Is it a community health provider? What were the characteristics? Because in a minute I want to talk about sensitivity analysis and how can the characteristics, either in the personnel or other, be changed or adapted or substituted? What were the components of the intervention that were delivered by specific staff? How long did the intervention take? What was the time span? Or another example is if it's a face-to-face meeting or if it's a one-on-one intervention, how long was the session with the participant? Because that's important to figure out what the cost was. Not only the cost to deliver the intervention, but whose cost from the perspective of either the health plan or the patient costs. If it's so expensive, if it's so expensive to the patient, not only in the resources to buy the different food or the exercise equipment, but if I have to spend an hour driving across town and another hour waiting to have a session with somebody and then 2 hours driving back, the time cost alone to the patient may be prohibitive for allowing the intervention to be successful. And how did the intervention, and this is key here, how did the intervention costs change in a different replication scenario? So change in characteristics of the target population, change in technology. And this is the key that I'm going to showcase, I guess, today. Back to study design quickly, minimize the burden on both the subjects and the research staff. So through many of the behavioral interventions that I've been involved with where we try to we have been successful at capturing intervention costs, it had to be a pretty minimal, modest instrument. So back to Russ's example, instead of 440 variable or questions that can be internally validated, you want to make it simple. We actually did a cost analysis at one point. If it exceeded more than 5 minutes a month for the staff to report their involvement in the project, we weren't going to be able to collect those data. And capture all resources and costs that would be required for future implementation, and differentiate those from the research and development costs. You know, if somebody asks me, why would we need to cost this out? You have your budget from your R01. Well, how much time is spent, especially in the front ends of most intervention project or large intervention projects, where it's the investigators coming up with the different instruments, thinking great scientific thoughts, IRB, consenting. What would you need to keep this intervention going in that setting or in a different setting versus what are the research and development costs? So I think I did say, and identify resources and costs that would vary in different scenarios. That's what I'm calling, in this case, sensitivity analysis. Excuse me. Primary outcome in this case, incremental. Economists use marginal, but I've been trained not to say marginal and instead use incremental difference. Incremental change in proportion vaccinated in this case. Total cost by intervention arm. Postcard versus IVR versus IVR plus postcard. So again, this was a randomized clinical trial of 3 arms. Postcard, IVR, IVR with postcard. And incremental costs per incremental change in the outcome of interest. In this case, we were hoping to look at change in the proportion vaccinated per change in cost. Most other large cost effectiveness analysis often use the other metric that many of you have probably seen before, and that's quality adjusted life years saved. And I'm not going to touch that today, but I could go on for a few hours about my fondness of that measure. But I do put up some references on that metric at the end of this. Sensitivity analysis, change in target population, personnel, substitution of personnel, doc versus medical assistant, and I think that would be the case maybe in some of the other examples given. Change in technology use. How am I on time? You're okay? Okay. Have the stakeholders involved. In this example, the stakeholders came to us. So it was more about us being open to being engaged by the stakeholders. And we were very lucky in that they were involved from thinking of this intervention, wanting to make a change on how they targeted flu vaccine reminders, to helping us be informed about what could be changed in the intervention for the sensitivity analysis. And because of their level of engagement, they were very willing to participate with the efforts that especially Joanne took on about capturing the resources and costs associated with the different strategies. So stakeholders are key. Findings, 12,285 were randomized to the 3 arms. And I'm not going to, I do have the second bullet, and we have more data on that, or Joanna has more data on that there were no differences in the outcome of interest. There was no differences in the proportion that were vaccinated. But older age, outpatient visits, prior receipt of vaccine, being an employee or a dependent, employee of Kaiser, were positively associated with receiving the influenza vaccine. Here's the interesting piece. Here are the total personnel costs by intervention arm. Note, boy, look at that. Look at that IVR. That's awfully expensive. Then we looked at software, hardware, and supplies. Boy, look at that IVR arm. It's almost as expensive as the other one. But I highlight the green line there. That green line is IVR T1 line, 1 telephone line. So backing up to personnel, For the IVR, we had the health educator help inform us about things. We had the database administrator to identify the patients, and that code, that SAS code or whatever code that wrote who are we going to send it to, didn't matter if it went out to 12,000 members or 400,000 members. Didn't change the time that database administrator or a program manager or data analyst worked. Informatics on how to push that out into the IVR world. The internist that helped inform medical issues. Voice talent. That's not going to change. Person only says it once for that 12,000. So again, back to hardware, software. So total cost per member in the group. Look at that IVR. It's awfully expensive. But what happens if we wanted to implement it to either everyone who is a target cohort for influenza vaccine? Kids, pregnant women, the elderly, those with chronic diseases. What if you wanted to push it out to 100,000? Or more importantly, what if you wanted to push it out to your whole membership? It was 5 cents per member per month. And and I know Joanna's messed around with this inside out and backwards. So this is where we demonstrated that if you look at your sensitivity analysis, if the outcome doesn't change between arms, that isn't the only thing to look at. Look at the economic impact of it. Look at the cost associated with different scenarios and how the implementation characteristics could change. So as noted in that arm, the findings were more expensive per member for the intervention, but the sensitivity analysis demonstrated it was more effective to use the IVR. And my punchline here was IVR was pushed out to our entire membership this fall. Lessons learned: engage stakeholders, engage stakeholders, and engage stakeholders. In our case, in our research group that's embedded in a health plan, be open to engagement. And that's often what we have trouble with, finding the time saying, yeah, I have time to listen, not as, gosh, can I charge this to my other grant, but to be open for opportunities to conduct these help them conduct these kinds of evaluations, and they could often lead to ideas for even better ones. In our case, I think we discussed it would have been really cool to have a flat, zero, no intervention arm, but we couldn't do that. As standard practice, we always send out reminders to target populations. And I think another one we ran into, identify all resources needed for the arm prior to implementation. We were, especially with the phone lines and the servers, weeded through, Joanne weeded through a lot of different issues around that after the fact. And consider, we didn't talk about or measure what would happen if we sent them multiple calls, multiple very inexpensive IVR calls. And again, I put up some references for both background on cost effectiveness, different places, different instruments to capture intervention costs. And so they're all there. Thank you very much.
Questions. This is another great set of presentations, and again, great you diverse kind of understanding of the context, approaches. We heard about a number of different study designs. So, thank you.
Am I in the right place?
You are.
And I think that Ali had a question to start with.
Hi. So I had a question for you, Deborah, about, because we've done a lot of text messaging versus auto dialer versus postcard kind of reminders. I was interested in the high costs of the IVR at Kaiser. I mean, for example, the message preparation was it's like $800 compared to like $30 for postcards. And it just, I wonder if you could comment, are you doing something that's, I don't know, more elegant and more expensive?
Should probably be down here answering these questions, but I would say because we established or implemented IVR technology, and I think it was because of some grants we had. I think it was a couple of grants where we were targeting asthma patients with asthma anyway. We already had the infrastructure there, so it began. It wasn't that we were buying new servers, buying new technology, but we did factor in things about licensing and things like that. And we had the message, we pretty much used the same message. Joanne, nod when I'm saying the right thing versus when I'm making something up, which is probably where I'm headed shortly. We already had the content from our postcard, so I think we tried to keep the content consistent. So I don't know if I'm getting
Well,
to
I was just so surprised because whenever we do something by mail, be it postcard or anything, comparing it to any kind of pre-recorded or autodialer or IVR, it's so much more expensive to do mail. And
well, it is in small sizes, and that's what we showed. That when we targeted 3,000 patients per arm, IVR was much more expensive than postcard. But if you extrapolate out to a bigger group, a larger population, that's when we saw the cost savings. It wasn't at the intervention population length, and Joanne's going to say something.
That's right. So with the server, what we did was we said there's an average of 12 projects per year that are use IVR, and so we took 1/12 of that cost. We recognize that for agencies that don't have IVR existing, it's going to be much more costly, but we wanted to demonstrate what we did.
And I don't think, and in my mind, is true implementation. You're not going to, if you're going to push it out and keep it going, you're not going to be buying a big server every year, or, I mean, the capital cost, and we could get into cost accounting on this, and we did go around with different scenarios on how to best capture that piece, but we feel pretty solid around that would be what our real costs to do that will be.
If I can just jump in on that, an area where I know not quite enough to be dangerous, but it's all Deb's fault about cost issues. Again, I think this is one of the key needs for implementation science is to report cost. The caveat is, and the good news is, that there are methods, and Deb has a number of the references, you can do this. You don't have to be, Nobel laureate health economist to do this. A lot of it is kind of accounting. But the caveat is you do need to do it in a standard way and be relatively comprehensive. And a lot of times people don't. I'll just give you one quick example, and we can move on to your questions. And one thing that Deb has taught me, for example, is often when people are reporting research studies, they don't report the cost to recruit patients or whatever. And the notion is, well, this is a research study and we had to do this. But if you're going to do that in the real world, you need to promote or recruit, somehow. Maybe not exactly the same way you would in a research study. And take that out. Yeah, you may not need the consent, but you do need to recruit. And similarly, like phone call things. I'm thinking a live phone call now. I've looked at a number of them, and huge variability, kind of like when Allie was puzzling over that. But if you look more detail, some of the people are, frankly, if you will, more comprehensive or transparent, and they include costs like training, supervision, and the huge key, getting wrong numbers and not getting people on there. Or like when you're going to meetings, you have staff driving out. They don't count that. They count just the cost when they're right there. So I think the issue is doing it in a standard and transparent way.
Okay, this is, I don't know who to direct this to. Maybe everybody has an opinion about kind of response to D&I more broadly. My very limited experience with, especially the implementation side, is that IRBs are very slow. So we would want to implement, things change, world is different, and then we wait for IRB review and approval and changing consent forms and all that kind of stuff. The other response, Ross, you had mentioned this, that importance of publication in that especially academic world, and for more senior researchers, maybe we can move beyond that. But especially for junior people coming up, that's a huge issue. And just wondering what kind of responses have been out there to address those kind of issues.
I'll start with, and you're here, right? And so what your IRB would be University of Colorado or?
I'm not.
Well, so here's how we're having luck with the IRB part of it, I think. We are basically, when we get a study that might be a 3 or 4 part study, we submit it in modules. So that almost like a participatory thing where to know what you're going to do in phase 2, you have to have done phase 1, and so, as you go through. And at least our IRB, and this took us a while to kind of get them on board with this, turned out the in-person meetings, just like all of we were talking about, the face-to-face meetings with IRB made a huge difference over email and phone. And so that's at least the modular part is really working well for us because these studies build on each other so much that if you want to tell every step along the way of what you're going to do over a 5-year study, it's virtually impossible if it's a 3 or 4 phase study. The publication part, I think, is, we're not going to say that no longer are, academic publications important, and I do think it varies somewhat by stage of the career. But I do think if people are doing implementation research, that they should think about that vehicle as the first step. Because what our data shows is that researchers think of their effective dissemination as, I do a publication, and then I have this media office, and they might write a press release on it. And that's pretty much what our data are showing. And just to think, if I'm doing an implementation study, I still need to do the publication, but the next steps of that might look a little different than I thought. And it's not just handing it to the PR department.
Other thoughts? Just a couple of quick points. I think not only for this type of work, but I think IRBs are an issue also for community engaged research, certainly for social media research. A lot of IRBs have huge issues with that. But I think they're also trying to change it and aware of their issues. In our own study, I talked about my own health report project. I'd say IRBs was probably one of the single things that slowed it down the most, because we had 9 different research sites, 7 different IRBs, and 7 different interpretations of what you needed to consent, what you didn't, whether you could use incentives, whether you couldn't, what type of, just that sort of thing. Partially as a response to that, and Deb or Julie might want to answer that, I think some of and again, it's easier to go and integrate it if you're part of a network, but I think other networks are trying to develop strategies where essentially there's one central one or one lead IRB that you kind of cede authority to for that study, so you don't get that. And often that can facilitate, particularly in these large studies or projects.
Well, and I'll touch on the publication part. The study's working with Dr. Glasgow. As soon as the IRB is approved, the draft of the first paper is in place. So I don't think lack of publication around D&I has never been an issue. I think 4 or 5 papers, but it's the important part. What are the methods? What's the conceptual model? Different issues around implementation science of the particular target population or other that you're considering here.
Very interesting talks. I had a follow-up question to Julie in terms of the practically how you approach when you say you're targeting, you're trying to understand and compare low versus high adopters. And I'm curious how you've operationalized that. I've done some work like that, and some will say, well, there's natural variation, and are these truly different or just part of natural variation that we're seeing? So I was curious how you approach it.
So if I understand your question, all we did was use adoption as a measure of high versus low. And so, for example, one of the initiatives is the use of electronic consults. So we use the proportion for each site, the proportion of electronic consults that they had that were in their database, the workload database, compared to, it was either, actually I think we measured it 2 ways, all consults or all outpatient visits. So it's just a measure of adoption. Now, whether that's due to natural variability or whether it's a true measure of implementation success, Honestly, we didn't really look much further into that because, again, we're sort of have to move along here, and we have to figure out who our high adopters and low adopters are and try to figure out the differences between them.
Are you using like top quintile, low quintile, or top quarter? Quarter,
Again, it's
or?
very pragmatic.
Yeah.
So we figured out how many sites we could reasonably interview if we were going to interview maybe 5 folks per site. So for most of the initiatives, that meant we could do about 8 sites total. So we took the lowest 4 and the highest 4.
Okay. All right.
Very, very practical.
Yeah. Okay.
I have a question for the group where you're getting ready for the next one or given the microphone. Did the measures and kind of the outcomes that we talked about here surprise any of you, particularly those of you from a more traditional biomedical perspective, where adoption or implementation or cost or whatever was really the primary outcome, rather than a biomarker? Or if you look at the figure in your book there that Borsika went over with Enola Proctor's model and that sort of thing. Those things aren't the usual thing that you see in terms of kind of what's the focus or the primary outcome. I'm just wondering if there's any concerns or if that's a surprise or uncomfortableness with people, or do we kind of communicate, or do you get why these things might be important if you want to kind of plug these gaps and address the 17-year issue?
And then I will complete over as well. You have a question that is response to that? Okay.
Sure. So this is for all the panelists, as well as perhaps Borsika, since she went over the PRECISE framework, and I hope I'm saying that right. PRECISE? Precise,
Everybody says
precise,
it different.
Whatever, tomato. Okay. So, well, we already learned earlier that there's the 61 different implementation science models, and now there's also the PRECISE evaluation criteria. And I see at the bottom that this is in one of the citations, it's PRECISE, a tool to help trial designers. So I'm wondering your thoughts on how much PRECISE should also be used to complement the existing D&I models, and kind of does it complement them in a certain way, or how do you think about that as you're trying to let it guide your trial design?
You start with that one.
I'll start. I say PRECISE just because the people that generally developed it are Quebecois, more Canadian French than anything else, but I have no idea. Everybody says it different. Just a couple things about that. I personally do think there's a lot of use for it. I don't see it as a different model or theory or framework. What I see it as is an efficient, transparent, and that word is important, way of describing your design. And what it does is show, and Borsika didn't have enough time, but that little figure, that spoken hub figure that you have in your book, once you've learned how to do those 10 dimensions, you can tell an incredible amount about a study just from that one little figure. And in my experience, it's helped a whole lot, because in the real world, those examples you had, those were kind of straw person examples. There's really no study ever that's been 100% pragmatic, or I wish they wouldn't use this word. The other word is explanatory, but for you it really means efficacy, or more basic, or under more ideal conditions. But what you can tell is what conditions was it more pragmatic and more explanatory. And to me, the reason that transparency is important is a lot of those things are related to potential for generalizability or translation. And I think by saying that, and again, I think we should be clear, there's nothing right or wrong about doing a more efficacy or explanatory study or a pragmatic one. The issue is just being upfront or transparent about reporting it, and then not claiming, if you're doing an efficacy study, that what you're going to do is going to automatically generalize to all the rest of the world. Somebody else?
That's true.
I was just going to add a very practical addition to that, which is that it's very helpful when you're writing a grant or submitting a paper to a journal that's not very used to this stuff to see an article like that. So honestly, I think it's also a way of shoring up that you in fact do know what you're doing, and a pragmatic trial, for example, really is scientifically sound. So I find myself using, maybe this is a terrible thing, but I find myself using that reference a whole lot just to shore up what I'm doing.
The other thing it's helped is, we didn't give enough background, is it was originated by the consort people. And all of you that publish in a medical journal know, you need to apply to consort guidelines. This has elevated both pragmatic trials and maybe at least inadvertently implementation science more than most things I've seen, because this is put out as well as the PRACIS criteria by the people that do consort work. And for those of you that are really interested, the originators are doing an update, actually. It's going to be called PRACIS 2. It'll probably be a year and a half before it's out and fully vetted.
Well, I just had a comment to the question you asked, Russ, about the outcome measures. And given what I've learned about D&I, I mean, I don't think any of the measures really surprised me completely. But we had an interesting discussion in our group over lunch just about how, like for the field that I'm interested in, it's relatively new and there's more and more research being done in that area, but a lot of the outcome measures haven't really been defined. And like I'm involved with a team that's doing an intervention right now, and there are guidelines available, and I think it's ripe to disseminate them. But we've had a lot of discussion on our team about the right measures to use, and I think that the ones that I see being used here make a lot of sense. I mean, how feasible is it? Is it practical to do? What is the uptake going to be like? So I guess it's really just more of a comment, and I'm sure there's probably others that have similar experiences.
No, and I think that the nice thing, and because I get that sort of similar question a lot of times from junior people, like, am I risking career suicide by entering this new field where there isn't anything? And you can look at it both ways. You can it is risky maybe because it is new and still developing, but I look at it the other way. It's exciting. It is a new field. In your field, like we were talking about, you could be the first. You can write about this stuff and have the original articles in the literature about how to establish these measures and build the frameworks. And so I think that's the way to look at it, because the D&I jargon and all that, it's really not the most friendly, accessible terminology. But if you explain what it is you're trying to do, there's all this research that's not being applied, and we need to figure out better ways to do that. Then people really get it. And that's sort of the way when I do the first public health training course for students, I always say, you have to be able to explain what you do to your grandmother. If you can't do that, then you need to back up and start over. And that's the same thing with our field. We still need to work on, I think.
Hello. So actually something you said just made me think of a question. So with pragmatic randomized trials, is the standard the same in terms of powering on an outcome? So like I actually work on the other side, like the explanatory trial, so we have a main outcome, you power on that outcome, it is your main outcome. Is the standard different?
Anybody else want to take it? Or I'll start and try to be brief. Two different answers. One, if you're writing a grant, you want to do what you said, the same old thing, and at least your primary one should be something that you're pretty solid on, that's a validated measure that you clearly have enough power on. What's different about D&I implementation science is because of this issue of context that Julie talked about much better, we have a much broader focus. So we're interested in a wider range of issues and that sort of thing. So generally, and just grantsmanship, at least what I do, is I'll put those things in generally as secondary aims or something. But I'm very interested in the who, what, where, why questions, those contextual type thing, as well as the other things some people might call generalizable or other outcomes like quality of life or what's the impact on the patient overall and that sort of thing. But again, a lot of the same principles of science and statistics and things apply. You want to try and have a valid, reliable measure. You want to have a general notion that your sample size is large enough to do that and you have enough statistical power.
And I think it depends a lot on who you're writing it to. So I always think about the reviewers of this grant or this study, what are they going to be used to seeing, and sort of slant it primarily that way. I don't know if we're covering much on hybrid designs during this, but the hybrid designs are kind of a new thing that kind of combine effectiveness research and implementation research. And in some ways, that can kind of let you get away with both, because you can have both some effectiveness outcomes as well as some of these developmental implementation outcomes. And then you can write it to sort of two different audiences for reviewers.
I'd have one last comment, and I'm going to look back to you, Ross. If the grant is being submitted to the D&I study section versus some of the other study sections out there, I've sat on Health Services Organization and Delivery and GEMS and PCORI. I think something that goes to D&I can look very different with respect to sample size and effectiveness, et cetera. It's about sample size. Do you have a large enough cohort to disseminate into, or number of settings where you're going to disseminate? They look and feel very different. The applications, the good applications that I saw, I would say.
Yeah, I think that's true.
So we are going to take one more question from the group, I think, and then I will take the last question.
Sure. It's not really even a question. I just wanted to share with you, having been a project coordinator for many years, implementation science is long overdue, and that we're finally getting to the point where when you're implementing all of these interventions, you are an implementation scientist. So we're now giving it an official name.
Right. That's great.
And so my last question is related to qualitative data and how much it is respected and accepted by the target audience, whether it's providers or other types of target audience. I think all of you talked about some sort of either mixed method or mixed type of data, and some of you actually emphasized the role of qualitative data, so if any of you wanted to comment on that. And especially Julie and actually Ross with your policy work as well.
Mm-hmm.
So I just have one sort of interesting anecdote, and really any of my colleagues who are participating in this can comment on it. So we did we're still working on the best way of sharing our findings, as I sort of indicated in our slide. And so we did have one presentation, albeit it was on the phone, but we had our key stakeholders, not the people at the facilities, but the funder, so to speak, the tippy-top office who was rolling out the initiatives. And so remember I said we had two groups, those who were focusing on the quantitative data, and then those of us who were doing the mixed methods, more qualitative. And I have to say they were much more interested in the quantitative data. And so this is different than getting it accepted in publications and such, because I totally agree with you. They are, many more journals are appreciating the importance of the qualitative data for informing the quantitative, these mixed methods approach. So I don't know if this one presentation was indicative of how things are going to go, or maybe we just didn't emphasize them enough, but they were and they have to report to Congress, and Congress is interested in, how much money did you save, and how many travel dollars did you save, where our group was interested in how you disseminate the findings. So again, it just depends on what your stakeholders are interested in. I think and I hope that the qualitative data, which really does focus on or will help us inform this toolkit, will be more useful to the field. But that one little presentation, I was very disappointed that they weren't focused on the recommendations that we had.
Yeah, I think that's all true, and I think the way Julie framed it in her presentation, combining the methods was perfect. It is sometimes counterintuitive. We have this study that Borsika knows where we randomize state legislators, and one group got a story and a qualitative data, another got more data to see what they would remember, act on, relate to, and surprisingly, the quantitative data did a lot better than we thought. Because, I used to work with state legislators all the time, and the old folklore was, 95% of the time a good story trumps the data. In this case, we found that it was different than we thought. So not only is the mixed methods, but you can also use it as part of your implementation strategy to see which method works better for different stakeholders. And I think it is probably stakeholder dependent, but we still have a long way to go in understanding that.
I would just add quickly, as we're getting ready for Allie's comment here, that over my career, I've become increasingly convinced of the importance of qualitative data and really the back and forth together. Generally, the quantitative data given still in many study sections, but fortunately not all anymore. And it's changing. They want to see the outcomes, which gives you the what. But the qualitative gives you the how, the understanding, and particularly going forward, if you want to replicate this, if you want to understand the boundary conditions and that sort of thing. So both with REAIM and other things, increasingly we've tried to bring in and integrate. Maybe one thing as a follow-up, we could send out for NIH, there's been a fairly recent report on mixed methods, kind of best practices for mixed methods that you might want to take a look at, particularly if you're submitting to NIH.
Yeah.
Because I'm a portable manager at the time, I gave the opportunity to Ellie to ask questions.
Great. It actually isn't a question. I was just going to add to what Russ said. I really strongly believe that we shouldn't be doing implementation science or pragmatic trials without a qualitative component because we don't understand what happens. To that end, Karen Albright, who's a qualitative researcher here, and I just wrote a paper about mixed methods and the challenges that, particularly in publication, because most of our mixed methods studies have to be separated because they're too long.
Yes,
If you include, the methods for both types of designs, it's often too long. So there are very few journals that really allow you to do that well. And I think that's one of the things we need to push on is the journals. And we did successfully just have a mixed methods paper, accepted, but it's been very difficult.